Good morning to all participants of the webinar. Today is our third webinar on vascular access handling. I'm Dr. Ashwini Ookalkar and have been administrator of a nephrology unit for the last 25-30 years. And I'm also a qualified pathologist and an auditor for Dialysis Center accreditation. I have written chapters in the Handbook of Dialysis for Technicians, which was published by Central India Nephrology Society. And I'm also been a faculty for certificate course and diploma course for dialysis technicians. And today you're here with me as a founder of Nephlearn, which is India's first app for dialysis technicians. So welcome to all of you on this third webinar in our series. Today we are going to talk about vascular access handling, which is so essential whether the patient is of acute kidney injury or whether the patient is of chronic kidney disease. And we are going to learn two things. What are the common complications that can happen and how to prevent these? We already know that temporary access is used for acute dialysis and permanent type of access is used for chronic dialysis patients, which may be tunnel catheters or fistula or graft. And what are the complications of the vascular access devices or the catheters that we insert? Most common is the infection that all of us see off and on in our units. Sometimes there may be blockages because of various reasons, mainly thrombus. And sometimes the catheter may actually break. And it may occasionally even dislocate. When a catheter dysfunction happens within 4 weeks of insertion, it is called as an early dysfunction. And if it happens after 4 weeks of insertion, then it is called as a late catheter dysfunction. Early catheter dysfunctions are usually related to insertion, and there may be a fault in the tip position, or sometimes sutures which are turned around the catheter instead of only on the flaps. These can cause constriction of the catheter. Both early and late dysfunction may be either static, in which there is often, you cannot flush, both early and late dysfunctions may be static. That is, very often we can see where we can flush a catheter, but we cannot aspirate blood from the catheter. And this is an indication that there is probably a thrombus formation there. Or they may be dynamic, in which the arterial and venous alarms buzz if we try and increase the blood flow for more than 200 ml per minute. And this is called as a dynamic dysfunction and commonly happens because there is a formation of a fibrin sheath. Even during catheter insertion, we can see complications which are common, like a minor hematoma formation at the insertion site. What is a hematoma? It is an extravasation of blood in the subcutaneous tissues and often appears as a blue or a black injury at the site. Patients and relatives often get alarmed seeing this hematoma, but it actually is of not much significance. Sometimes at the site of hematoma, we may have a local infections. Hematomas usually form when there are multiple attempts at puncture and the search for the vein is more. Occasionally, there may be an arterial puncture because we must remember that the arteries and veins anatomically often run together, and therefore it is very easy to mistake them. Even in sites like the femoral artery and the femoral vein, it is very difficult to distinguish the positioning of the two. And very rarely, we may have arrhythmias. There are more rare complications like hematomas, which are so large that they compress the airway, or there may be a major trauma to large vessels resulting in hemorrhage, or there may be cardiac perforation even with tamponade. Also has been seen pneumothorax and hemothorax. What is pneumothorax and hemothorax? It is the collection of blood or the collection of air in the pleural cavity. Sometimes there may be thoracic duct injury, which is seen as a white colored fluid that is known as chyle. And there may be nerve injury because the brachial plexus runs very close to the subclavian vein. There may be sepsis, and there may be air embolism or thrombosis and pulmonary embolism. All this happens because, if you know, the catheter actually resides in the heart. It is inserted through the superior vena cava and it reaches the atrium. So we have the superior vena cava and then the atrium. And therefore, all these complications can occur. Also, we must remember that the catheters, which are of temporary nature, are usually made up of polyurethane or some rigid material, and therefore more likely to cause these complications. But interesting is that the patients think that the catheter is only present in the neck, and they do not know this fact. But we as technicians should know this fact, and therefore we must handle these catheters extremely carefully. So coming back to this X-ray, in which we can see the tip in the atrium and the superior vena cava and then the catheter itself. So if the tip is in the atrium, there are many points of contact, and these may cause endothelial injury and therefore over a period of time thrombus formation. Sometimes they may irritate the endothelium or the atrium, and they may cause arrhythmias. Arrhythmias are irregular heartbeats. If catheters are inserted from the left side, there are many more points of contact, and the incidence of thrombus formation is found to be more. Same way, there may be a hemothorax or a pneumothorax in the pleural cavity. There may be an air embolism, or pericardial tamponade is the collection of blood or any fluid for that matter in the pericardial sac. The pericardial sac is not elastic and cannot expand. So the only space which is left if there is a large collection of blood in the pericardial sac is that it causes pressure on the heart, and therefore the heart is the one which is stopped. That is known as cardiac tamponade. However, the more troublesome is the septic complications or the infections that we see with access. And it has been found in this study that 26% of the patients with catheters had hospitalizations due to infections, as opposed to patients with a graft or a fistula, which had fewer number of hospital stays because of sepsis. And what are the sources of the organisms? So the organisms which are present on the skin can easily deposit on the catheter, or at the site of insertion, sometimes because the skin has been punctured, there can be infections. The hub, which we commonly handle as technicians, can be a source of infection because our hands can contaminate the catheters. And finally, very rarely nowadays, that the infusions that we give to the patients in the form of saline or IV injections can sometimes be infected themselves. And all of these can result in even blood infections. So there are 4 types of infections. There may be just a simple colonization. Here we have to remember 3 words: colonization, contamination, and infection. Contamination is when our fingers touch the catheter and the microorganisms from the hands get transferred to the catheter. That is known as contamination. In colonization, the bacteria from the skin and surrounding areas actually grow into the catheter, but they do not cause an infection. They do not cause any symptoms in the patient like fever or redness or pain, etc. That is colonization. And the third is infection, in which the bacteria actually grow into the catheter, also cause symptoms to the patient like fever, redness, pain, and so on. So we have to remember that sometimes there may be just plain colonization. Sometimes there may be infection at the site of entry or the exit site, as we call it. And this may be of 2 types. It may be just at the exit site, or it may be at the tunnel. If the infection or the redness and swelling is within 2 centimeters of insertion, then it is known as an exit site infection. If it is beyond 2 centimeters, then it is known as a tunnel infection. The third is the vascular infection around the tip of the catheter. And if you know, very often when the catheter has been removed in a patient suspected of sepsis, we send the vascular tip The double lumen catheter or the catheter tip is cut and sent for culture along with the blood culture. And this is the reason why this tip is sent for cultures, because we have to determine whether there is a vascular infection or a pericatheter infection. And the last is the bacteremia, in which the blood is also infected and resulting in sepsis. So as we have seen, the catheter infection may be local, either exit site or tunnel infection, or it may be a systemic infection, in which case it is called as catheter-related bacteremia or central line associated bacteremia. So what is the exact definition of catheter-related bloodstream infection? First of all, the patient must have clinical manifestations such as fever, redness, swelling, pus maybe. There must be at least one positive blood culture from a peripheral vein, and the patient must not have any other source of infection which is apparent. And then the same organism is isolated from the catheter segment and from the peripheral blood sample. So how do we prevent these infections or even other complications? First is the choice of site. Second, the choice of catheter length, sonographic guidance, our infection control policies, and surprisingly, duration of catheter in situ is not so important. The impression I had was that when the duration of catheter is longer in situ in the body, there may be more chances of infection. But otherwise, it has been found in a study that the incidence of infection is most in the first 5 days of insertion of the catheter and not after 5 days of catheter insertion. And so the protocol has been evolved that as far as possible, a catheter should be kept in the body only for a week and not longer, especially for acute kidney disease patients. But if a patient is found to have the need for chronic dialysis, then we must use a catheter which is like a tunnel catheter rather than a temporary catheter. So let us take a look at which is the appropriate site for insertion. Is it the subclavian vein, the femoral vein, or the internal jugular vein? So let's take a look. सबक्लेवियन कैथेटर लगाने के बाद मरीज आसानी से घूम फिर सकता है.
आईसीयू, that is internal jugular vein. ये कैथेटर लगाने के बाद मरीज को गर्दन हिलाने में बहुत सी प्रॉब्लम होती है.
फीमोरल कैथेटर लगाने के बाद मरीज को आईसीयू के बेड पे ही लेटे रहना बेहतर रहेगा. सबक्लेवियन कैथेटर लगाने के बाद कॉम्प्लिकेशंस होते हैं, जैसे सबक्लेवियन वेन स्टेनोसिस. इसके बाद एवी फिस्टुला बनाना बहुत डिफिकल्ट हो जाता है.
इसके साथ साथ बहुत सारे कॉम्प्लिकेशंस भी होते हैं, जैसे कि हेमाटोमा, थ्रोम्बोसिस, स्टेनोसिस, फिब्रिलेशन.
फीमोरल कैथेटर लगाने के बाद कॉम्प्लिकेशंस हो सकते हैं, जैसे इलियोफेमोरल थ्रोम्बोसिस, फिस्टुला, आर्टेरियल पंक्चर और हेमेटोमा. ये कभी-कभी जानलेवा भी हो सकते हैं. सबक्लेवियन वेन कैथेटराइजेशन के बाद ग्राम पॉजिटिव कॉलोनाइजेशन इंफेक्शन कॉमन है,
और इसमें इन्फेक्शन होने की भी बहुत से चांसेस रहते हैं, जैसे कि ग्राम पॉजिटिव बैक्टीरिया इसमें ग्रो हो सकता है. फॉर एग्जांपल स्टेफिलोकोकस.
फीमोरल कैथेटर लगाने के बाद इंफेक्शंस हो सकते हैं जो ग्राम नेगेटिव ऑर्गेनिजम्स के होते हैं. In this video, there are three sites which have been compared. The subclavian vein is very convenient for patients because it is just in the neck. But at the same time, if subclavian vein stenosis occurs, then it is very problematic for the patient to create a fistula later on. And therefore, for chronic dialysis, we do not recommend the subclavian vein insertion at all. Also, the other complications like brachial plexus nerve injury or hematoma or hemorrhage or cardiac tamponade and perforations are commoner with subclavian vein insertions. The second site, that is the femoral vein, is again very convenient to do. But if the patient has a femoral vein catheter, it is recommended that he be bedridden, and therefore beyond the ICU, the patient cannot have a femoral vein walking home. The third is the option of the internal jugular vein, which is the recommended option, and therefore it is easy to use It is less complications are seen with the internal jugular vein, but only thing is that the patient finds it a little discomfort to use the internal jugular vein. But the recommendation finally is that the first attempt should be made in the internal jugular vein. The second factor which affects the occurrence of complications is the catheter length. If a right-sided insertion is done, then to reach the superior vena cava, it must be a 13 to 16 centimeter long catheter. And for the left-sided insertions, a 16 to 20 centimeter long catheter. Very often, if the right side insertion fails, and we have one or two attempts, and we decide to go ahead with the left-sided insertion, we must remember to change the catheter for the longer side. Because if the catheter has a retracted position, then it may result in an early dynamic dysfunction. And if it is outside the vessel, it may result in a static dysfunction. The most recommended way to put in a catheter is under sonographic guidance, because this helps not only to visualize the needle tip within the vein, but it also helps to confirm the patency of the vessel in the first place. If there are any close variations or relationships, and what is the target vessel diameter and depth. And surprisingly, because of reduced number of attempts and handling, there is a reduced rate of catheter associated bacteremia. We have already spoken about insertion of the catheter, but there are also infection control policies related to pre-procedure, procedure, and post-procedure. In the pre-procedure, it is very important to calculate the right dose of the anticoagulant. Very often it has been seen that the anticoagulant is deficient, the dose is less, and in which case clotting or thrombus formation is commonly seen. The temperature of the machine and these other settings must also be checked, because at a high temperature, hemolysis may occur. And of course, catheter reuse has to be checked, whether there is any disinfectant remaining, whether there are microclots formed, and whether adequacy is there. Because all these will ultimately result in indirect infections in the catheter. One must wear full personal protective equipment and treat the catheters with full respect. And it is better if two people are handling the catheter at one time, one assistant and one main person. In the case of fistulas, to avoid aneurysms, we must take care of the needling techniques and use a rope ladder technique or a rotating technique. And then these are the steps that we must take in order to reduce the chances of infection. Hand hygiene is a must. Then comes the aseptic measures, and then 2% chlorhexidine alcohol for skin antisepsis. During catheter care, we must be careful about hand hygiene at all times, but regular inspection of the dressings must be done. So these are the barriers that we must use, or the standard precautions that we must use during catheter insertion, exchange, as well as during handling of the catheter. Again, during the procedure, the rub and scrub protocol is one of the most important that we can do. So if any microorganisms are present at the hub, these may not contaminate and these may not colonize the catheter and lead to further infections. Skin disinfection with a 2% chlorhexidine is mandatory. Also, machine settings should be checked. If there are many alarms in a machine, one touches the touch screen several times, and this alone has been found to contaminate the catheters. Similarly, for medications which are given intravenously, one must monitor for air embolism, and one must also monitor for complete sterile precautions. The CDC has several guidelines and checklists which can be used. A checklist has the advantage that although it looks very simple and you feel, oh, I'm anyway following all these protocols, there's no need to remind me each time. But there is a reason why a checklist is used, and it has to be a simple one-pager. The checklist, after a period of time, one tends to reduce the steps. If you go to your units and audit yourselves today, you will find that out of these 9 steps, you may not be performing 1 or 2. But in the back of your mind, you keep feeling that you are performing all of these 9 steps. I encourage people to use checklists because checklists are very, very essential in critical areas. And handling a catheter is one of the critical areas. A very fine example of using checklists is the airlines. In an airline, when you enter the plane, every flight that you take, and there may be thousands of flights per day, every flight that you take, you are reminded to you put on the seat belt, to open the window covers, to where the oxygen masks are, and what to do in the case of an emergency. Why do you think by now we all know it, right? We know how to put the seat belt, and we know where the oxygen is going to come down and what to do when they say evacuate, evacuate, evacuate. But this simply means that we need to be reminded of these things. Post-procedure, again, rub and scrub protocol is very important, and a heparin lock. Here, many people make a mistake and just put a standard 2 ml or 3 ml into the catheters. But each catheter has the ml or the volume written on it, and one must see that volume and accordingly put in the heparin lock. So it may be 1.8 ml, 1.9 ml, 2.8 ml, and so on and so forth. One must remember to flush with saline to remove all blood, and proper reuse of the dialysis must be done. Coming to dressings, this is a dicey point, and many times we have seen that dressings are changed at the end of dialysis. No, dressings are meant to be changed at the beginning of dialysis because you have to check so many things in a catheter. When should ideally the dressing be changed? If it is a transparent, semi-permeable and self-adhesive dressing, then one must change it only at the end of a week, not more frequent than that. However, please remember, if the dressing is loose, is damp, if it is soiled, and if it is no longer occlusive, or if there is any evidence of inflammation, then one must change the dressing immediately. If we are using gauze-based dressings, then they must be changed at each hemodialysis treatment. And again, these may be weekly. So what is it that we have to check under the dressing? At the catheter exit site, we must check for redness, for any exudates, for tenderness, for pain, for swelling, for the suture integrity, and for the catheter position. If we change the dressing at the end of dialysis, we will miss all of this, and actually the patient may have more bacteremia than desired. Very often we can see catheter dysfunctions like a kinked catheter or a broken catheter. Sometimes dislodged catheter, especially in rural areas, the patients are not able to understand properly and they are not able to take care of the catheters properly, and bleeding. So what to do? If it's a broken catheter, do not reinsert and do not inject anything into this catheter either, but contact your nephrologist, go to a vascular surgeon, and they will remove the piece. If it is a dislodged catheter, do not reinsert it because the dislodged catheter already has organisms growing on it. If you push it in and try to take a suture yourself, you're going to increase the chances of sepsis. Now we come to a fistula monitoring. And the fistula must be assessed for edema, whether it is limb edema or facial edema, alterations in the pulse and the thrill, any collaterals, lack of pulse augmentation, bleeding, numbness, pain, and any signs of infection. And this must be regularly monitored at least once a month. So what are these things going to inform us? The pulse and the thrill are very important. The thrill will first indicate if there is any kind of stenosis happening. And then the augmentation test and the elevation test will further tell us if it is an inflow or an outflow stenosis. The arm elevation test informs us about an outflow stenosis, where if you raise the arm above a certain level, the blood in the fistula should drain to the heart and therefore there should be a collapse. But if there is an outflow stenosis, then there is no collapse, and this is what is seen. In the case of an augmentation test, it checks for inflow stenosis, and when you apply a tourniquet or some kind of occlusion to the vessel, then the blood flow should get augmented or enhanced. The thrill should get augmented. But if there is an inflow stenosis, then there would be very poor augmentation. These are the common complications that one can see in a fistula: thrombosis, Steele syndrome, stenosis, and aneurysm. We have already spoken about stenosis. But for prevention of thrombosis, it is essential that we use a proper anticoagulation, use a good heparin lock, and most importantly, monitor the hemoglobin levels. With erythrocytosis, that is, if the hemoglobin rises above a certain level, more than 12 grams per dl, then it is found that there are higher chances of thrombosis. Similarly, if the erythropoietin dose is also higher, this may also result in thrombosis. And central venous stenosis, which is easily identifiable, you can see the collaterals here. You can see the edema in the limb. Maybe there may be edema in the face also. But the first indicator is that after needle removal, even before all of this happens, is when we remove the needles during dialysis or at the end of dialysis, there is very much prolonged bleeding. And this is one of the first indicators. Another indicator is that the venous pressure is gradually rising. The basal venous pressure is the pressure which we record at the first dialysis. So if supposing your basal venous pressure is 40 millimeters, and we find that over a period of 1 or 2 months, this has increased 3 times, then one must think of a stenosis. Steele syndrome is, as the name suggests, the blood is stolen, rather the blood supply is stolen. So in the fistula, the blood circulation is so enhanced that the blood is no longer diverted to the distal fingers, and this results in gangrene. An aneurysm is a ballooning of the blood vessel. This may finally result in a rupture, which is life-threatening. How can we avoid an aneurysm? Well, the simplest way is to use a rope ladder pattern of needling or a rotating site pattern. And the second is to avoid a tourniquet at all. We can just use gauze piece, apply pressure for about 10 minutes after removal of the needles, after closure of dialysis, and the bleeding will stop. This takes some practice, and it takes a lot of effort to convince the patient and the relatives that you no longer need a tourniquet. And don't worry, there will not be any bleeding from this site when you go home. Having said that, wherever we are using tourniquets, we must make sure that they are not tied for a long period, especially in the first few uses of the fistula. When the patient himself is new and does not know anything, we must remind the patient that you should go home and remove this tourniquet after 2 hours. And finally, all these complications can be prevented if we do a regular examination and review, whether it is a fistula, whether it is the catheter. We also have to continue to monitor the venous and arterial pressure. So I request all technicians to not forget this step when you are connecting the patient to dialysis. Please do monitor the venous pressure, arterial pressure, and please do note down your recording findings. If we do not have findings recorded, we cannot make an assessment of whether there is a gradual increase in the venous pressure indicating early stenosis. And similarly, one must keep checking the blood pressure.
Do you want to learn more about dialysis techniques? Then go to Nephlearn app on Google Play Store for more details. Nephlearn has more than 113 videos on various dialysis techniques. Test series on every topic with 24/7 live chat support on Nephlearn. Nephlearn provide live webinar for more demonstration and one-to-one mentor support if needed. Buy now, visit on Play Store to get the Nephlearn app.
So I would like to announce to all our regular viewers that we are going to launch a new course very soon in the new year. And we will be beginning live classes in our application for the various courses, especially the dialysis techniques for beginners course. Just like I spoke about the checklists, even if you are an experienced technician, these videos are very useful to revise things and to review whether you are performing all the tasks and the processes that you should be performing. Also, we will be beginning a new webinar series, but first we will have a small get together on the 24th of December. So wait for it, wait for those fun activities, because all work and no play makes Jack a dull boy. If you like this video, Please do share, subscribe, and download our app Nephlearn from the Google Play Store and enjoy what the videos are all about. Thank you.